afternoon, Mr. Chairman and colleagues. Thank you for the invitation to present to you. I'm going to reverse my slide, sorry. I'm going to be talking to you about the raindrop, which is previously known as the View Plus in Europe, the experience we have at Ultralace, which is a group of clinics in the UK. I'd like to acknowledge my disclosures that I'm supported by Vision Optics and my colleagues who have assisted me in this study.
The sound is very weak.
Sorry?
Microphone.
Is that better? No?
No.
Better now?
Yes.
Thank you. So this is, the raindrop is a corneal inlay, and this is what it looks like in the eye. That is a flap which has been lifted, a normal femtosecond flap, and the inlay is placed on the visual axis. I'll show you a brief video of what it looks like to implant it. A 150 micron excimer laser flap, femtosecond flap is laid, the flap is lifted, the inlay is planted on the visual axis, and then the flap is replaced very gently to avoid washing away the inlay, and then the flap is smoothed. A very simple procedure. Now this corneal inlay, as I said, is placed under 150 micron femtosecond flap. The effect of this is to create a raised area in the central cornea, which creates a reading in a non-dominant eye of the patient. So it's a unilateral procedure. The inlay itself is like a jelly. The closest thing I could relate it to is like the capsule of a lens, and it has a similar water content and refractive index as the cornea. So it does not change the refraction of the cornea, it changes the curvature of the cornea to create a reading segment. It is 2 millimeters in diameter and 32 microns thick in the center. As you can see from the topography on the left-hand side of the screen, it does raise the central cornea just a few microns. The compound is a hydrogel with a high water content. And now the advantages of the raindrop inlay are that it's reversible. So it doesn't soothe the patient, it can be taken out very easily by anyone who knows how to lift a femtosecond laser flap. It's also placed in the superficial cornea, only 150 microns below the surface, which means that it's easily accessible for implantation. If you need to manipulate it, you can manipulate it, and if you need to remove it, it's easy to remove. And concomitant LASIK is possible at the same interface. You don't have to create another layer to change the refraction before implanting this. It's also invisible cosmetically. You cannot see this implant. It's because it's completely transparent, it does not obscure the retina. If you're trying to examine the retina, and cataract surgery through it, although I haven't had to do it, should be very simple. And it doesn't require expensive equipment to get centration perfect. It's very easy to center just under the microscope. And if it's not centered correctly, when you examine the patient postoperatively, it's very easy to replace and center a new one without this expensive equipment. This is a photograph of the inlay in place. The pupil has been dilated. This is not typical postoperatively, but it is the only way to demonstrate the inlay because it is almost transparent. It's very difficult to see and even more difficult to photograph. But there it is. Now we at Ultralace have 30 clinics around the United Kingdom and Ireland. We have a model whereby an optometrist who is a non-operating eye care professional does consult the patient and determines what surgery the patient needs, whether the patient would be best off having LASIK, lens surgery, or the raindrop. I only meet the patient on the first day of the surgery. I have to confirm that the right decision has been made for the patient, that the patient is suitable, that the patient understands the risks and benefits, and I have to do the surgery and do a post-operative check, all within 30 minutes. The follow-up is usually done by a non-operating eye care professional, these optometrists. Again, obviously I manage the complications. Now these raindrop patients are booked into a routine surgery diary. There's no special modification of my diary, my laser diary, that has to be made for this. So these patients will be put in my operating diary very much like the LASIK or LASIK patients. In this study, which we did, there were 3 surgeons who did the surgery. As I said, it was in the non-dominant eye, roughly equal numbers of male and female, and these patients were all presbyopic. The usual selection criteria for LASIK and for a multifocal type of procedure are relevant. So we avoid patients who have critical night driving occupations, like people who drive lorries or trucks for long distances. People who have high expectations. The patient doesn't accept monovision. Now what I mean by that is that this is not creating monovision, but there's a little bit of reduction in the distance, uncorrected distance acuity in the operated eye, because there's a little bit of a myopic shift. So I have to check that the patient will tolerate that. And so I do a monovision test to confirm suitability. So it's not monovision that we are creating, but I do the test to confirm suitability. So obviously these patients were all emmetropic, they were near plano, with very low astigmatism. We needed reading assistance with good uncorrected distance acuity, with poor near visual acuity, corneas which are above 500 microns, and average size pupils. I don't want people with big pupils, very big pupils, or very small pupils. There were 58 eyes operated on. As you can see from these data, they were all patients who were near emmetropic with low astigmatism and good distance vision. Post-operatively, these patients all had a slight reduction in their uncorrected distance vision in that one eye that was operated on. And the reason for that is because when you look at the spherical equivalent, all of these patients became a little bit myopic, about 0.5 diopters. And this continued for the 6 months of the study. The important, this graph shows the uncorrected near visual acuity is an important component. That is the red bar, and all the patients had better than 20/40, 96% of patients had better than 20/40 near vision, which is very functional near vision for most visual tasks. Their uncorrected distance vision was slightly reduced, and that was because of the myopic shift, as I said before. Of course, we all have 2 eyes, so with the other eye they were seeing well in the distance, so we checked the binocular data. The binocular data was very good. What could these patients achieve? These are some of the tasks that we try to achieve in terms of intermediate and nearer vision with more and more discriminating tasks. And as you can see, all of the patients in our study could read books, could read magazines, see the instructions. Most of the patients could start to see very small, much smaller print, 85%, and that was acceptable to a large proportion of the patients, and I'll come to the satisfaction levels later. This is what's called a bubble graph, and what this consists of is on the vertical axis, it's in visual acuity ratio, where 100 is 20/20. All of the patients had good distance vision, because that's why they came to see us for their near vision. So in the horizontal axis, the near vision was poor. And each bubble represents a number of patients, so the bigger the bubble, the more patients. So as you can see, preoperatively they had good distance vision and poor near vision. Post-operatively, of course, they had shifted across, so that a lot of the patients were now seeing very well nearby, and some of them had some reduction in their distance vision. And this persisted and continued for the subsequent tests. That's at 1 month, and at the last follow-up, they were seeing well in the distance, they were seeing well nearby, and most of them seeing well in the distance. Now, what are the complications with this? We had some patients who developed a haze. And what this is a slight lack of clarity overlying the implant. It occurred in 12% of 7 patients and happened at about the 3-month period. This was with an old drug regime protocol, follow-up protocol. We have now modified this, and this has reduced the amount of haze which occurs at this 3-month period. patients do develop haze, we give them some more steroid and that tends to clear it. This is halos. This is thanks to my colleague Dr. Olkowski, who is doing a study in America, and it shows that very few patients, most patients had no halos at all post-operatively, and a few had a mild or moderate halos, which tended to get better with time. Now, we rate all our satisfaction levels in our clinics according to 5 criteria, and the best level being couldn't be better, which is very difficult to please some of these patients. They're very discriminating patients, and they're very difficult to please. And we have the next level down is pleased with results, satisfactory, and right down to regret having had it. Regret having had it means that the patient wishes that they've never had any surgery done to their eyes. None of our patients were in that category, and 93% of the patients were in the satisfied categories or better. And this is similar to our levels of satisfaction with routine LASIK in patients who range from 20 years of age up to 55 or older, and also for patients who are having binocular surgery to improve their distance vision. So this is a very good result for patients who are looking for a presbyopic result. I'm not going to go into too much detail, but this is a concurrent LASIK study by Dr. Baragan, has shown that this procedure can be used in patients who have a refractive error as well. In other words, they are myopic or they are hyperopic, between about +3 and -6, and he has got very good results by putting this in there for non-dominant eye of these patients. So he did 45 hyperopic patients, 24 myopic patients, and I'm not going to go through this in great detail. So uncorrected intermediate and distance, uncorrected near and intermediate were good. Again, we found a bit of a myopic shift, so the distance vision was slightly reduced up to 12 months. So in summary, the raindrop is effective for treating emmetropes, hyperopes, and myopes with concurrent LASIK. It has future potential possibly in patients who previously had LASIK, perhaps in pseudophakic patients, and there might be an opportunity to do bilateral implantation in the future with high patient satisfaction. Thank you.
Great.